Smoking prevalence is declining in England at around 0.7 percentage points to 0.8 percentage points a year, but we can certainly do better than this, and I was asked to provide some indication as to what one might do in the northeast to get the smoking prevalence rates declining faster, using data that we have on the trends as they are at the moment, what they would look like if things had been slightly different, and where they might go if we were able to improve some of our key performance indicators. So I've prepared a set of slides to look at this, and I'm just going to take you through those. First of all, let me just reiterate the aims. So what I'm trying to do is to look at the current trends in smoking prevalence, both in the north east and in England as a whole, and to look specifically at factors that affect the trends in prevalence, and that's uptake and quitting primarily. And I'm using data from our smoking toolkit study, which collects data from smokers and recent ex-smokers, in fact the population as a whole, on a monthly basis, and has been running since 2006. But I'm also going to use data from the annual population survey, which we only have data collected in this particular way for the last few years. And because in the northeast we don't have such a big sample for the smoking toolkit study, I'm going to look at annual population survey data for the key prevalence trends, but we don't have the more detailed information from that survey on quit rates and uptake rates, so I'm going to use the smoking toolkit data for those. So looking first of all at the big picture, what's been happening to the smoking prevalence in England as a whole and in northeast, you can see that the red dotted line shows what's been happening in England, and you can see that smoking rates have been declining at, if you look at the equation there just under the dotted line, at 0.77 percentage points a year, which is actually quite good. It's about as fast as it's been going down at any time since the 1970s. What you'll also see is that the rate of decline in the northeast has actually been a little higher than this, at 1.13 percentage points a year, but of course it was starting from a higher baseline at the start of the measurement period, so it remains higher. But I think the key thing I want to get across here is, although the rates are higher in the northeast, the rate of decline does look as though it's been a bit faster than it has in the country as a whole. And that means that you must be doing something right, but also it means it's going to be quite challenging to get the rate up even further, and I'm going to discuss more about how we can do that. If we look at the factors that contribute to smoking prevalence and trends in those, now we're talking about data from the smoking toolkit study, and I haven't put confidence intervals around these, although they are quite wide. What you can see is that around 30% of 16 to 24-year-olds in England report that they've ever smoked, and that's a kind of proxy for uptake. It gives you an idea about what the uptake rates are, because very, very few people start smoking after the age of 24. But what you can also see, and this probably explains to some degree why the overall prevalence is a bit higher in the northeast, is that in the northeast the uptake rates are a little higher, so they're somewhere between 35 and 40%. So that's one area where the northeast has perhaps not been doing quite so well as England as a whole. If you look then at quitting, then there's two factors that contribute to that. One is quit attempts, and the other is quit success. So the number of people who end up quit is the number of people in a given period who try to quit, and then the percentage of those who succeed. And these actually are different processes, so we need to treat them separately. What you can see in this slide is that the quit attempt prevalence has been very, very similar in the northeast as it has in England as a whole. It's actually been a little higher for most of the period that we're looking at it. It was a little lower in 2015, but for the other 3 years it was actually higher than that. So they're quitting at a slightly higher rate than in England as a whole, probably, although the confidence intervals probably overlap. And then when it comes to the success of those quit attempts, and by success here we're actually only looking at short-term success. In the smoking toolkit study, what we do is we ask people, have you tried to quit in the last 12 months? And are you still quit? Or have you gone back to smoking? So the period over which we're looking at it can be anything from a week all the way through to 12 months. But on average, it's going to be around 6 months. So that's why the figures are actually quite high relative to the long-term quit rates. But they give you an idea about what those long-term quit rates are going to be. And what you can see is that, again, the Northeast has actually, for 3 out of the 4 years that we're looking at here, has actually been doing rather better than England as a whole. And that's probably what's mainly contributed to the fact that smoking prevalence is declining a bit faster than it is in England as a whole. If you put the quit attempt rates and the quit success rates together, you get an overall quit rate, which is what proportion of the population of people who have smoked at all in the last 12 months are not smoking now. And you can see, as you would expect from the figures I just showed you, that in the Northeast, for 3 out of the 4 years that we've been looking at it, that the rate has been higher than it has for England as a whole. A little bit lower in the last year, but overall the rates are higher. So quite a good story there to tell for the Northeast, particularly relative to England as a whole. But that then raises the question of what can we do to get those rates up? Well, what I've done is to model what would have happened under 3 different scenarios, or 3 changes to what's actually happened in the past. One of those is to say that instead of the quit attempt being somewhere between 30 and 40% each year, the quit attempt rate, let's say we'd managed to get it up to about 45%. Now that shouldn't be necessarily that hard, because actually in the United States, for example, the rate is more like 50%. So it is achievable. And then if we do that, we can also look at what happens if we maintain the current quit success rate at around 20%. The quit success rate has actually gone up recently. It's not absolutely clear why, but possibly e-cigarettes have played a role in that. But if we can maintain that at 20%, that would be excellent. And then if we can reduce the uptake rate, which using a number of calculations from the data I showed you, we estimate that in the country as a whole it's been around 0.4% of the adult population who've taken up smoking, obviously mostly among young people, in any one year. If we could get that down to 0.3%, then that's not an unrealistic target. Anyway, if you put all that together and you see what would have happened if those parameters have been in operation over the last few years, you can see that in the country as a whole, we would have got the smoking prevalence rate down by around 1.36 percentage points a year, which is would be quite a considerable achievement. But in the Northeast, we would have actually managed to increase it to 1.54, which would be a pretty good rate of decline, and something that if we had been doing that ever since the 1970s, we would have very, very few smokers left in the country. So let's consider these as possible targets for prevalence reduction. To increase the rate of quit, at which people are trying to quit to 45% a year, to maintain the success rate as its current relatively high rate at 20% of quit attempts a year, and to reduce the uptake from around 0.4 percentage points of the total population to around 0.3. And let's project forward to see where that would take us over the next 10 years. So this graph shows what it would look like, and what you can see is something pretty dramatic, which was that starting from 2015, in the country as a whole, by 2025, in around 10 years' time, we would have essentially got to our target of almost eliminating smoking. We would have got smoking below that key threshold of around 5% a year. 5% of the adult population. And what's more, if we were to apply the same metrics to the northeast would, because it would have come down relatively faster than in the general population, would have got to that same point by 2025. So those are the kind of figures that we're talking about if we're going to achieve these kinds of targets. They're not unachievable, but they're not the sort of thing that will happen if we just carry on doing what we're currently doing. So we do need to think about how we can do things better. Well, there are a number of things that we can do that have an evidence base. Obviously, there's lots of things that people might like to try that are certainly in the offing and maybe worth trying. But there's certain things we can do that actually have an evidence base that we can do better. And even just doing those without necessarily doing anything heroic, I think we can get to where we want to be. One of these, obviously, is increasing the real cost of tobacco. And the cost of tobacco is absolutely critical. It's not just the tax, it's actually how much the tobacco costs for the consumer. And at a regional level or a more local level, what we can do is to amplify the impact of the tax increases with improved interdiction to address the issue of smuggling and illicit supply. This is important. We can also look at, for example, demand reduction, helping to educate and motivate the population to buy their cigarettes from legitimate sources and not to undercut the prices, recognizing that actually the main harm from illicit supply and smuggling is not necessarily that the cigarettes themselves are much worse for you, because cigarettes are incredibly dangerous anyway, but rather that they're undermining cost as a key driver to smoking cessation or a key deterrent to smoking uptake, and that is really critical. Mass media campaigns continue to be absolutely critical, and unfortunately, as I'm sure you're aware, the spending on national campaigns has gone down quite substantially, and there has been an impact to that. So the question is, what can one do at a regional level to get the best bang for one's buck in mass media campaigns, either by amplifying national campaigns such as Stoptober and so on, or running regional specific campaigns. The third area, which is one that I think there is a considerable amount of headroom for room for improvement, is implementing what we call very brief advice, or VBA, in primary care. As things stand at the moment, despite the fact that general practitioners are receiving across the country something in the region of £80 million a year in incentive payments through QOF to advise smokers to stop, in fact, despite what's being recorded, only around 25% of smokers report having received the kind of offer of support that we know makes a difference. Now, if we were just simply to increase that from 25% to 50%, it would make a substantial difference to the rate at which people are trying to stop smoking and the rate at which they would succeed. So I think this is a key area where we can do more. It's a bit of an old chestnut, because people have been looking at how to do this in the past in many different ways, but they haven't actually been applying any behavioural science to it. They've been applying common sense approaches, which, as we know, don't always work. The fourth item on this list is the introduction of a concept called Stop Smoking Plus. Stop Smoking Plus is not a specific model of smoking cessation, but it's a kind of broad template, and the key elements of it are that there is an offer for every smoker. At the moment, with our stop smoking services, we're only really reaching a very small proportion of smokers, because the reality is that although most smokers want to stop, most smokers actually don't want to engage with a clinical service in order to do that. But what we can do is to make sure that we get the right offer for everyone. So those people who are willing to engage with a specialist service get a really high quality service that they can get the benefit from, and that will give them the best chance of stopping. For those who don't want to engage with that but are willing, for example, to take a stop smoking medicine, we know that that can provide a substantial uplift in their chances of stopping smoking. And so with those smokers, we focus on making sure that they get the medicine they need and that they use it properly. And then the third tranche of this is what we call self-support, which is providing evidence-based advice to smokers on how they can do it themselves. And just to give you an example of a very simple piece of advice that would make a big difference to a lot of smokers, that is, if you've decided you're going to quit, then you're much better off quitting abruptly rather than trying to cut down first. The success rates are very different. And that simple piece of advice could make a big difference to smokers if they got it and acted on it. Other things that this self-support method can do is to give them accurate information about things like electronic cigarettes, about how to get the best use of their licensed stop smoking medicine if that's what they choose to do, and so on. It can provide them access to apps and websites and so on, which, although they don't have a strong evidence base, I think there's reason to believe that some of them might make a difference. And they're free, so they don't cost us anyone anything, basically, because they're provided as part of the sort of service that people who like to make apps provide. And then the last item is reducing access to tobacco, which is obviously critical, and I know the North East has been very, very active in, but we can always do better, and that is restricting outlets and looking at how we can extend smoke-free into areas that currently we're seeing relatively high rates of smoking. Obviously that is something that would have to be done with very close consultation with the local population in order to make sure that it sticks and that people accept it. But restricting availability to anything, whether it's alcohol, smoking or anything, we believe can make a difference to the behaviour itself. So the key points, I guess, to come from this is that smoking prevalence is declining in the North East, actually slightly faster than the national average, which I think is a real success story for this region. And it's probably because the quit rates have been a bit higher, because the uptake rates have probably been a bit worse. Just looking at realistic targets for how one can improve on this, it looks to me as though increasing the rate of quit attempts to 45% a year is achievable. And all we then need to do is to maintain the quit success rates we've currently got at 20% and reduce the uptake from 0.4 to 0.3% a year. And really that could put the North East on a path to 5% smoking prevalence within 10 years, which is what we're all trying to achieve. So it is doable. It will require a concerted effort and resources being put into it. But I think you can see from the modelling that it's not a pipe dream to think that we can achieve this target.